from the American Academy of Pediatrics.
Mental and behavioral health emergencies in children are on the rise.
The AAP has new strategies, resources, and recommendations for improving care delivery for the pediatric population.
I think prevention is really the root of solving this problem.
We really need to think about care linkages, starting from schools to the pre-hospital system, to the emergency department, back to the medical home.
Plus, new research highlights the importance of the medical debrief.
I think that when we use this method called advocacy inquiry, what we're doing is we're sharing what we have seen and then asking somebody about it.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about treating mental and behavioral health conditions before they become emergencies.
I started exercising again during my pregnancy, not because I wanted to lose weight or get in great shape. I'm not sure either of those things will happen right now, but because I started to realize how much exercise boosts my mental health.
I'm so glad you're taking those mental health moments because right now so many people, kids included, need mental health services, and it can be challenging to find them in an overcrowded and overworked healthcare system.
I can imagine. I know the youth mental health crisis is affecting everyone, and pediatricians are having to step up in ways we never imagined during our training. We need help.
Today, we have some of that help right here. Dr. Mohsen Saidinejad and Dr. Lois Lee are authors on the AAP's new policy statement and technical report, The Management of Children and Youth with Pediatric Mental and Behavioral Health Emergencies.
Dr. Saidinejad is a professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. He also serves as the director for the Institute of Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harbor, UCLA.
This is Dr. Lee's second visit with us. She's Senior Associate in Pediatrics in the Division of Emergency Medicine at Boston Children's Hospital and Associate Professor of Pediatrics and Emergency Medicine at Harvard Medical School. Drs. Lee and Saidinejad, welcome to the show.
Thank you so much for having us today.
Same with me. Thank you so much. It's a pleasure to be with you guys.
All right. So in the United States right now, how many children need mental health services and how many are actually getting the right ones? Is there any way to really quantify this growing demand for care?
Despite the importance of this problem, we actually don't have real-time data to know and understand how many children are receiving emergency care, much less needing psychiatric and mental and behavioral health care in other settings as well. What we do know is that numbers were increasing before the COVID-19 pandemic, but since the COVID-19 pandemic, we have just had emergency departments take on more and more children who are presenting with these mental and behavioral health emergencies.
This is a dynamic problem. The numbers continue to increase. So even if we had the number right now, a day from now, the numbers would have changed and they would have increased. And this is part of the problem. We are not only continuing to get more and more mental health visits to the emergency department, but these visits are becoming more complex, and they are also by children who are younger and younger. We didn't realize this, but recently, the age group of 5 to 9 years of age have increased in their number of visits to the ER by 24%. And now suicide is one of the top 10 leading causes of death in this 5 to 9 year age group, which was unheard of before. So it is important to highlight that this is a dynamic problem that continues to increase in scope and size, which is one of the reasons why this has become such a crisis situation for us.
Wow. And how equitable is the distribution of mental health services? Are we seeing some communities more in need who just can't access them?
Well, equity and inequity really is distributed throughout different populations. So one easy example to think about is rural versus urban and suburban populations. The federal government actually tracks this information. So they can actually give you a scoring system based on where you live on your access to mental health providers. So you can imagine children living in rural areas and in states that are more rural have significantly decreased access to mental health providers. And that's just by physical distance. But then we can look at certain other high-risk populations, including our LGBTQ plus youth, where we know there are at increased risk for mental and behavioral health emergencies, but there can be barriers to accessing care. We also know that there are increasing rates of suicide among Black adolescents, as well as American Indian youth. Again, we don't have numbers for this year. The numbers that we have are at least a year old, but these are important populations for us to consider. And then more specific populations include children who are of immigrant families, those in the juvenile justice system, from families whose preferred language is not English, or families from cultures that perhaps have more difficulty talking about mental health disorders. All those children also have disparities in access to both getting care and maintaining care.
Yeah, I would also add to that children who are in foster care facilities, children who live in group homes, they are also disproportionately affected.
And Mo, many of these kids with issues wind up in emergency departments, which really weren't designed for this type of problem. Are there steps EDs can take to better handle these crises?
Yeah, to your point, as Dr. Lee mentioned, there is an increased prevalence on these children coming to the hospital emergency departments. And they come to an emergency department that wasn't really designed to handle mental health emergencies. So I would say one of the things that we can do is to make sure that we have a good screening process. So at least when these children come to the ER, we can get a sense of which one of them needs a more immediate and urgent evaluation by a psychiatric specialist. And we know the entire country is shortage area for mental health. And we did just talk about the fact that rural areas are more affected by this, but the entire country is a shortage area. So we have to be very careful with our limited mental health resources. And this is why screening is so important, so that you can identify those who the services need to be prioritized for. So that is definitely one of the elements. And then obviously beyond that, we know children are going to wait a little while until definitive care by mental health providers. So we also need to figure out what these children will be doing in the ER while they're waiting and boarding, because boarding is another huge area that we are facing in the emergency department.
You know, I'm very lucky that where I work, both in my rural private practice and in the urban federally qualified health center, we have collaborative mental health services. But for practices that don't have mental health services on site, how can they prepare to handle these crises?
Well, many states actually have adopted a system that we first started in Massachusetts, where primary care providers can work with mental health specialists, both for education, but also for consultation. And that gives the primary care provider the skills to do initial screening and actual treatment for more common varieties of anxiety, depression, and ADHD, which many pediatricians were doing, but gives them actually the skills and the knowledge to feel confident in prescribing more of the common medications used for those disorders. And then for children who may be more complicated or may need more advanced pharmacotherapy, these practices have easy access to a consult, a mental health specialist, with whom they can discuss their patients in a really relatively rapid fashion. And some practices are even able to incorporate mental health providers into their own practices as well. And there are over 40 states in the U.S. who have adopted this model, and many other states are continuing to consider it as really a way to use the pediatrician in the medical home as a foundation for the mental health services for children who need them.
And that's a good look at a state level. If we're talking more about large hospital systems like the Children's Hospital of Philadelphia, Boston Children's, or even UCLA, have you seen practices they can adopt to cope with these issues?
So one of the very interesting phenomenon that technology brings with itself is the ability to have somebody sitting at a remote location acting as an expert and cover a variety of different hospitals within their system. So that telehealth process actually does exist in a lot of bigger hospital systems. And not only that it infiltrates to the smaller hospitals affiliated with that, but they can serve as consultants even in the rural communities of their region. So telehealth is definitely one of those ways. But for that to work, those agreements need to be steadfast, agreed upon in principle ahead of time, so that you know exactly under what circumstances, what number do you dial, who's going to be available, do you have 24/7 coverage, and what is the extent of coverage and what's the levels of liability for that remote coverage. So it does require a mental health professional to be contracted for service, but that ability to have this remotely done, it really allows that regionalization of care or even nationalization model of care to make this really limited resource, being a mental health professional, to be available and stretched out as far as it can.
I think we'd all love to see communities beyond just the healthcare profession address these issues. As we advocate in our communities for change, what sort of things should we be asking for?
That's a great question. I just saw a headline today that the federal government is actually putting in $88 million into schools to provide more mental health as well as substance use resources. And that really gets to the children and youth where they are, right? And with teachers and other educational professionals who see them every day.
Yeah, I would say, schools definitely is a important kind of contribution. We also have this sense that more and more mental health problems are being recognized. So that is why the ERs are where they are, because parents are more vigilant. They're referring more. The schools are more vigilant. They're referring more. Primary care doctors have a process in which mental health evaluation is part of their regular annual physical examination and history taking. So I think the problem in a way is that we are becoming more aware and we're referring more, but then we don't have the infrastructure to support all of this influx of new children who are potentially diagnosable with something that's mental health related. And again, to Dr. Lee's point, it really requires more federal dollars, creating better infrastructure, better policies, better legislature. It is a problem that really needs to be recognized because it's dynamic, it's moving fast, it's getting bigger and bigger by the day. And I don't think that infrastructure is not only keeping up, but infrastructure is actually diminishing to make this a bigger problem moving forward.
I think another important point for advocacy is mental health payment parity. We know for a long time that mental health providers and children with mental health disorders have not been able to receive the necessary services. And part of that is because providers have not been paid to the same degree as for medical conditions. So I think parity around payment would really help with access.
I know there have been ideas about changing medical education to include more training in mental health. And I was curious if you thought that that would be a way in which we could help treat more of these patients as well.
I think that would be very important. I think back to my training, and I really feel like I didn't have any formal education in the emergency department, but also in the primary care and subspecialty setting. One important thing is to talk about lethal means counseling. So if you do have a child or youth you're concerned might potentially be suicidal, talking not only to that patient, but also to their family to restrict any lethal means. And of course, medications are important to talk about. That's an easy place to start. Other poisons and knives. But wherever you live, you should also talk about access to firearms in the home. And that's an important message for prevention.
I would just add, playing a little bit of a devil's advocate on the other edge of this double-edged sword when it comes to training. I think one of the issues, and some of the professional organizations fall on this side of the court on this one, that we're not really talking about the solution to the problem is for us ED folks to be better trained. Because the problem is really infrastructure, capacity, resources, and space to take care of mental health. And some people would argue the more we train, the more they will come. So in a way, it's one of those situations where there are things we can do. I completely agree with the lethal means counseling. I also agree with us being able to recognize which patient can be discharged safely from the ER and which patient I just don't feel comfortable letting go. I think there's more to it. I think recognizing the scope of the problem and having a little bit more insight into this would be a good compromise. I think some training definitely, but I just wanted to point out that there will be some resistance in making statements that emergency medicine clinicians should get a lot more training on how to manage mental and behavioral health. This is not something that everybody is on agreement about.
So this topic is far too broad to cover completely in one podcast, but if you could each think of one takeaway for our listeners before they read the policy statement and technical report, what would they be?
I think given the depth and breadth of this problem, we really need to think about innovative strategies with care linkages, starting from schools to the pre-hospital system, to the emergency department, back to the medical home. And we need to think about ways where families can access care, as we had discussed already, maybe in schools, in the community. And if we can provide more resources for people to get care in more places, then hopefully we'll see more children presenting to the emergency department with true emergencies, because we'll always be there for them. But if we can reach out to those children and families before it becomes a true emergency, I think that's really the best way to care for these children and families.
And I completely agree. I think prevention is really the root of solving this problem. I think as more and more children are coming to the emergency department, it is important for us to realize that the majority of these can be easily and safely managed, and that we need to have a good screening process to be able to identify those who are at greatest risk. And not only the ED visit itself, but afterwards, the ability to connect them to some form of mental health follow-up visit is extremely critical, because we know that more than half of children who should have a mental health follow-up don't get it within 30 days. And we also know that those who do have a much lower chance of either doing something more harmful to themselves or others, or coming back to the ER with the same complaint.
Those are some excellent takeaways to remember. Doctors Lee and Saidinejad, thank you so much for talking with us today.
Thank you for helping us highlight the importance of this issue.
Yes, it's been a great pleasure talking to you, and I hope everybody will go and check out the new policy statement and technical report when they come up.
And to read that new policy statement and technical report, The Management of Children and Youth with Pediatric Mental and Behavioral Health Emergencies, go to aap.org/podcast.
Coming up, we'll look at ways to debrief our trainees after medical encounters. Joanna, if your NICU is like the ones I know, it's a high-stakes environment where you're also trying to teach everyone from medical students to senior fellows. How do you respond to your team when something doesn't go as you'd hoped?
You know, that actually happens all the time. I jokingly call all the premature infants backstabbers, a term I borrowed from a funny nurse practitioner I loved working with, because the more you try to craft a plan for them, the more they like to change the clinical game on you. So I always tell my trainees that this uncertainty is a part of medicine.
Oh boy, is it ever. Most days go smoothly in the hospital and clinic where I work, but we have students there too. And I wonder if I shouldn't take your same approach, even though the stakes may be lower.
I love that idea. I think we could both use pointers on how to debrief better. And I know just the person to brief us on them, Dr. Maya Neeley.
Briefly, Dr. Neeley is an associate professor of pediatric hospital medicine at Vanderbilt University and lead author on a feature in pediatrics, This Encounter Isn't Over Yet, The Importance of Debriefing. Maya, welcome.
Thank you so much for having me today. I appreciate that y'all pulled that article and that you want to talk about it further, and would just like to quickly acknowledge my wonderful co-authors and colleagues who helped me on this piece, Drs. Joe Gigante and Travis Crook.
Well, thanks to all of you. And where did this concept of debriefing come from? And what makes it such a popular concept in medicine and particularly in pediatrics?
Well, the concept originated from the military, where people would kind of go back and review how a particular event went to learn lessons for the next one moving forwards. And I think that so much in medicine, like you just said, is uncertain and complex. And there are always things we can pull out from every encounter to think about how we could do better in the next. And so I think particularly in pediatrics, it works because kids present with so many different variables, so many different illnesses, depending on their ages, so many different symptoms. And so I think this is the perfect way to afford both teaching and coaching and feedback and reflection in a really wonderful way.
So what sort of situation should prompt one of these debriefings?
I think most often we usually debrief after a critical event. So that could be a near miss, that could be a transition to a higher level of care. We'll often do it in the simulation realm when we're trying to practice a real life case scenario. But there has really been an impetus, just like you were saying, David, to increase our use of debriefing to normal clinical encounters. Like we spoke about, there are always ways to improve. And I think as long as you're thinking about a particular aspect of patient care, whether that be communication, whether that be teamwork, whether that be an opportunity for increased knowledge, these are all things that we can review in a debrief session.
You know, when giving feedback or debriefing, I always think about psychological safety, particularly with trainees, because they're being asked to do a job that maybe isn't something they love or a subspecialty they want to go into. And then there's this power dynamic between attending and trainee. So how do we make the debriefing environment safe?
That is so true, Joanna. And I would say that when we utilize the term safe learning environment, I think what we're trying to get to is a place where learners can feel like they can grow through their missteps. And part of that means admitting there was a misstep in the first place. And I think one of the best ways that as teachers we can do that is by showing our own vulnerability and sometimes normalizing things. And I think that we do that by sharing of our own experiences sometimes, or just by saying something like, that was really difficult. I have been in so many encounters like that in the past, to normalize the fact that sometimes missteps occur.
You know, when we're teaching, it's easy to fall back on just telling our learners what we want them to know. But are there ways we could reflect with them through this process so they're coming up with alternative ways of speaking to or treating patients instead of just telling them what we would have done?
Yeah, I think one of the things we do in medicine and in life a lot is make assumptions for why somebody said something, assumptions about why somebody acted in a particular way. And I think that when we use this method called advocacy inquiry, what we're doing is we're sharing what we have seen and then asking somebody about it. So the way that we describe in the article to do this is to use a 3 kind of worded approach called I saw, I think, I wonder. And that describes what you saw, what you might have assumed or thought related to it, and then wondering what the other person thought of it and wondering what their experience of it was. That way, I think it provides this wonderful space in which your learner can reflect on what you saw and think about why that actually occurred from their perspective and lens.
I mean, how long does this all take? Because it seems like it might get pretty in-depth and, you know, busy clinical settings, time is sometimes a luxury there.
I totally agree with you. And I'm not the most efficient person to begin with. What I would say is that there are some debriefs that require a lengthier time. And there are some debriefs, particularly when you're trying to concentrate on one particular focus that the learner has pulled out, that really only need to take a few minutes. You just have to make sure that you're concentrating on one thing. I know that sometimes as teachers, we can see 5 different things that we can improve on, but not all of them need to be talked about today or concentrated on. I think it's really important to concentrate, especially on what the learner has already identified as the biggest issue with whatever was identified in that patient encounter.
Dr. Neeley, I saw that you had an incredibly helpful article, and I think that we have learned a ton about this topic today, and I wonder if you have any final thoughts for our listeners.
Oh, I love that.
That was fun.
I think that always, 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 when I have worked with learners, the thing that they always ask for is more. I would like more to grow. And I think sometimes we let the busyness of the day or worry about how we're going to make time for giving them more. But I think if we can just kind of carve out a little bit of our space intentionally to afford them time and a conversation about a patient interaction, I think it can really go very far in their learning and their growth and their professional identities.
I love having us be more intentional about that. And Dr. Maya Neeley, this was great. Thank you so much for joining us today.
Thank you so much for having me, and thank you for all the wonderful work you do. You're so appreciated.
To read the feature, This Encounter Isn't Over Yet, The Importance of Debriefing, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, I have never gotten to drop my middle child Sellers off at school. And this year, we are going to fly up, rent a minivan, because in my mind, that's the best way to get a bunch of stuff out of a storeroom.
Definitely.
Get that room stocked, and then just enjoy the town, and hopefully I'll get to take some of his friends out to dinner and find out what they've been up to.
Oh, that sounds so fun, David.
I'm looking forward to it. How about you?
My Say Ah is that I had my 20-week ultrasound recently, my anatomy scan for baby, which for neonatologists is a very stressful time. And it went really well. And the MFM was actually like, oh, it's so good to give good news. Because, I texted it and then I made the MFM do it all over again. But it was nice. She was very patient with me.
Oh, that is great news. Thanks for keeping us updated. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call and on Twitter at Peds on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll bring you an immunizations omnibus.
We'll talk to Dr. Sean O'Leary about RSV, COVID, pneumonia, and influenza. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.